Good afternoon, everyone. My name is Anne-Marie Corrado, and I am thrilled to be the moderator for this session titled Implementing Contingency Management in RAAM, a Quality Improvement Project. Before we begin, I would like to take the opportunity to introduce our speakers. To begin, I would like to introduce Dr. Tanya Hauck. Dr. Tanya Hauck is an addictions psychiatrist at the Center for Addiction and Mental Health and an assistant professor in the Department of Psychiatry at the University of Toronto. Her research interests include the epidemiology of addictions and addiction psychiatry in Ontario. I would now like to introduce Himmat Dhillon. Himmat completed a Bachelor of Science in Biology at Western University, and he is currently a medical student at Midwestern University in Glendale, Arizona. He is very involved in the field of mental health and addiction, where he has had numerous volunteer experiences at the Brant, Dhillon, Norfolk RAAM Clinic. He also enjoys engaging in scholarly activity where he has had a diverse research experience, including wet lab research, retrospective chart review analysis in patients with colorectal cancer, and quality improvement research. I would now like to introduce Basant Dhillon. Basant is a level 2 student in the Health Science Honors Program at McMaster University. As an engaged member of her community, she is an active volunteer at the Brant, Dhillon, Norfolk RAAM Clinic. There, she has gained valuable knowledge in the areas of mental health and addiction, served as an advocate of mental health support systems, and fueled an interest in understanding social and environmental factors of health. Her experience in the RAAM Clinic also includes assisting with quality improvement research. She looks forward to further opportunities of inquiry in the area of addiction. And finally, I would like to introduce Stephanie Rochon. Stephanie is a regulated pharmacy technician, supervisor, and coordinator of the Brant, Dhillon, Norfolk RAAM Clinic. She has previously managed addiction medicine clinics and pharmacies to integrate services and improve access to evidence-based treatments in rural communities. So welcome to all of our speakers. Now, before I hand it over, I just want to remind people that there is a help button that is located at the bottom left of the screen. So if you have any technical difficulties at any point, please feel free to use that help button. And finally, I also want to remind everyone that there will be time for questions and discussion in the last 15 minutes. So please put your questions and questions into the chat box as they arise. Thank you very much, and I will now hand it over to our speakers.
Hi, so thank you so much. Thank you to everybody who's coming today at this time. The last talk of the day is always challenging before a weekend, so we really appreciate it. And we hope this is more of a discussion as well. Also just want to thank our other two co-authors from CAMH who are not presenting today, but have also really helped out in the analysis and assessment of this project. Okay, so just our backgrounds. We don't have any financial support or conflicts of interest. I do just report that my fellowship was funded through Bellwood Health Services, but we have no other disclosures and no sources of bias were identified in this talk. So our goals today are to talk about and describe the process of implementing a standard prize-based CM program, contingency management, in a RAAM clinic for the treatment of stimulant use disorder, to critique the outcomes of this implementation in a standard RAAM clinic, and to discuss a quality of improvement process that we went through to improve particularly human resource limitations to the implementation of a CM program. So this is the Brant, Dhillon, Norfolk RAAM Clinic. That's where all of this is taking place, and I'll just give a little bit of an overview. So this is a RAAM clinic that is a collaboration between 5 different agencies, as well as a number of other partner agencies in the community, including Haldimand War Memorial Hospital and Haldimand Family Health Team. We are located in Brantford, Simcoe, and Dunnville, Ontario. So in different days of the week, the clinic moves to different towns. These are the 5 partner agencies, so St. Leonard's Community Services, the Brant Community Healthcare System, the Canadian Mental Health Association, the Aboriginal Health Center, and the Grand River Community Health Center. And as is standard in a RAAM clinic, patients self-refer or are referred. We provide services on a drop-in basis. And we have psychiatry support through an integrated care model practice with CAMH in Toronto. And so just to give a little background, when the clinic opened in 2018, it was pretty rapidly obvious that stimulant use disorder, stimulant use was a major concern and presenting concern for patients. And the most common substances of concern presenting to the clinic were opioids, alcohol, and stimulants. That said, we do treat any substance use concerns, whether they are in those categories or otherwise. However, we realized very quickly that stimulant use disorder, especially concurrently with opioid use disorder and opioid agonist therapy, was extremely common. I put up this news article from a couple of years ago. This is from 2019 and really still holds true, that services for individuals who use stimulants, particularly if there are concurrent mental health disorders or concurrent mental health symptoms like psychosis, there's a lot of stigma. There are very limited resources that people can access and treatment that people can access. And this is still really an ongoing concern across the country and in our community. So just want to highlight that. But Stephanie and I have given, a talk on kind of the background of stimulant use disorder treatment, and there's some overlap, but we wanted to specifically talk about implementing contingency management in this setting, for these reasons. So I just wanted to give a little bit of a background on CM, just in case anyone isn't familiar with it, and it certainly isn't widely available. And just to backtrack a little bit more even, stimulant use is really an increasing concern in Ontario and in North America. And the rates of stimulant use and related emergency department visits have been increasing. So we've started to see more and more visits for this reason. And despite this increasing clinical need, there's still no well-established, broadly effective pharmacotherapy for stimulant use disorder. So unlike opioid use disorder or alcohol use disorder, we don't have on-label first-line options. Everything we use in terms of pharmacotherapy is an off-label use. And so a number of antidepressants, anti-craving medications, and now there's investigation into replacement therapy with stimulants. Those are still all off-label applications. There's still ongoing research into the effectiveness of those treatments. And certainly we do provide pharmacotherapy, but there's nothing that is really the same as it is for alcohol or opioid use. So psychosocial treatment is really the mainstay of care. And compared to no intervention, any psychosocial treatment, this is from a Cochrane review, but any psychosocial intervention really does improve adherence and abstinence by the end of treatment. I don't like this quote entirely for the stigmatizing language that it uses. I just wanted to highlight that the importance of psychosocial treatment and that it is really the mainstay of stimulant use disorder treatment. So contingency management is a type of psychosocial treatment really based on behavioral principles. It was really developed over the 1980s and 90s and uses principles of operant conditioning, and specifically where the frequency of behavior is modified by its consequences. And so when we look at sort of standard operant conditioning parameters, we're really looking at reward learning, where there's positive reinforcement. We're not looking at something like negative reinforcement. This is very commonly used in a wide variety of fields, so particularly in child psychiatry or pediatrics. It's used in geriatric settings as well. And it's used really just in all sorts of other settings that we don't think of. So for example, in marketing, you buy 5 coffees and you get 1 free. These are all kind of the same kind of principles of reward-based learning. And so based on these principles, there was the development of contingency management. And it's the application of this behavioral therapy often used in substance use treatment. And its basic principles are you find a target behavior that you can measure and that's important to the client involved. So for example, drug abstinence, if that's the goal of the client, or attending group, for example, if that's the goal. So you want something you can measure. You don't want something like good attitude, which you can't objectively measure. You want to frequently and objectively measure that behavior, and you want to provide concrete reinforcement that is contingent upon producing the target behavior. And there has been research into this, that contingent reinforcement is effective compared to non-contingent. So when there's a reward contingent on the behavior, there was a substantially higher sort of result of abstinence from substance use if that was the goal. So the research is incredibly extensive and detailed in CM. A lot of it is now 20 years or so old, but really detailed studies were done to figure out every kind of aspect of this, that contingent reinforcement works, what kind of reinforcement, what kind of substances, how to really do this. This has really been done in depth, and unfortunately it hasn't been applied nearly as widely as it could be. And then, the kind of prizes that are sort of provided. So I'll get into that in a minute. Some other things just to consider is, we could do this in theory for a variety of substances. Stimulants and opioids have been felt to be ideal because they can be measured several times a week, and you'll get a reasonable sense of whether the person has been using or not. But given that there are incredibly effective life-saving treatments for opioid use, and that abstinence or detoxification is not recommended, we didn't decide in our clinic that it would be a good idea to do this for opioid use. Similarly, cannabis can only be measured after 30 days of abstinence, so it's not really very useful. And tobacco and alcohol, particularly with a breathalyzer, is not very helpful because you'd have to measure several times a day. Benzodiazepines maybe not detected at all by immunoassay, or may be present for a month at a time as well. So stimulants in particular are suited for immunoassay as something that can be measured within a couple of days. So coming back to, this has been extensively studied for stimulant use. This is not, an experimental treatment. This is really their guidelines. This is included in the ASAM principles. It is recommended in meta-analyses and review papers. So really, among the various psychotherapeutic and behavioral treatments, it has the most consistent and strongest evidence of efficacy, at least during the treatment phase. There are a couple of variations. So there's been extensive comparison of voucher and prize CM. So voucher being basically cash equivalents of amounts, and in all CM, the amounts, as there is a longer period of abstinence, the rewards go up. So that's another kind of principle. So the first week, the first time that somebody samples, they would get a certain reward, and that would go up with each increasing reward. Prize CM involves drawing for prizes. So instead of just getting a certain amount of money, drawing out of a bowl, usually a prize bowl, and that prize bowl has a small number of very large prizes, a moderate number of medium prizes, a lot of small prizes, and about half of non-winners, so half of just motivational quotes. That just allows it to be cheaper. So it just allows, because of that randomization and sort of lottery system, you basically can spend less money than you would if you were just giving out cash, which, given the resources and the difficulty in accessing resources for this, so really the biggest barrier is getting funding to run this program. It's actually really important to know this. A number of studies have shown that CM is effective. It has a moderate effect size, which is great for a psychosocial treatment. And it works in a wide variety of populations. So when we decided we wanted to implement this, one of the reasons was, compared to a lot of other interventions, this is effective in individuals who may be dealing with homelessness. This is effective in individuals who may have concurrent symptoms like psychosis. And if you think of a lot of other psychosocial interventions, they would be excluded. Individuals in these categories might be excluded from research. So this was really exciting to us to think about using something that was targeted towards really anybody presenting to the clinic, regardless of what symptoms they might have. So first of all, we just wanted to clinically implement this, and then kind of look at how to do that in the RAAM clinic. So I'm just going to hand over to Stephanie now.
Thank you. So our clinic used the standard contingency management protocols outlined in the book by Nancy Petrie. Most of the protocols are 12 weeks of treatment with twice weekly testing for the targeted substance. The guide outlined, as Tanya said, 2 possible methods for CM, one using prizes and one using vouchers. Our clinic decided to go with prizes as it's more cost effective than using the voucher method. Our clients also really like the instant gratification of receiving prizes immediately. Next slide. So we implemented contingency management, setting up a 12-week program. Patients came to the clinic twice a week. We coordinated their testing with other visits like counseling, case management, and medical appointments. This improved compliance and assisted them with tackling other goals like housing, ODSP, or referrals to residential treatment. This was offered to clients with a stimulant use disorder that had the overall goal of abstinence, and they could commit to coming to our clinic twice a week. One of the challenges we faced and the clients faced was transportation. So we often set up clients who are on ODSP or Ontario Works with medical travel, or had clients reach out to family and friends to assist them to getting to the clinic. Clients with a history or a current gambling disorder are not applicable for the program, or if they are prescribed any type of stimulant medication. Next slide. So this is the standard contingency management prize calculator. We found this in the literature, and it outputs the number of small, medium, large, and jumbo prizes, and the quantity of each of the tickets to put in the prize bowl. In a couple slides over, we'll be showing a picture of the prize bowl. And as you can see, based on this chart, there would only be 1 or 2 jumbo prizes, 10 large prizes, and a few medium. The bowl itself would then be filled with mainly small, mini, and quotes. Sorry, just go back one. This was also dependent on if you choose rolling or static admission. Our clinic trialed both. And initially we started with static admission, where we had 12 clients start and finish at the same time. But we found that we were missing that window where clients are most motivated to stop using. So we wanted to strike when the iron was hot, and the other clients couldn't wait for another 12 weeks. So we have ongoing rolling admission at the clinic. Next slide. We used immunoassay test strips for contingency management for methamphetamines and cocaine. This became a challenge as there was a huge shortage over the last couple of years due to COVID, and we had to conserve our test strips and seek out multiple vendors. Test strips are essential for the program, though, because you can't use chromatography as you need the results immediately. Next slide. The prize cabinet was a key piece for clients. It helped them to stay motivated throughout the program, and they were very excited about the potential prizes. So we kept 1 or 2 of the jumbo prizes at the top and made sure that the clients had access to see all of the prizes. Initially, we chose prizes that the staff felt the clients would like, and this was based on our overall budget. Our goal was always to try to maximize our funds and provide this to as many clients as possible using limited resources. We did use prizes from the literature, but also slightly modified things like boom boxes, as they're currently not a popular choice of clients. Next slide. This is just a sample of small, medium, large, and jumbo prizes. Our clients actually provided feedback to us in terms of the prize selection. So we were able to fine tune our purchases to things that they actually preferred to have. Like initially our staff bought like toothbrushes, journals, and toothpaste, but we quickly found out that they preferred chocolate bars, candy, deodorant, nail polish. In larger prizes, we tried to match towards the population. So things like slow cookers that could be easily plugged into, like motels were popular, small TVs and tablets. Next slide. This is our prize bowl composition. So we used the CM calculator to calculate this. So 50% of the bowl was motivational quotes and 50% was prizes. The monetary value for the prize increased based on the ticket category. So small prizes were anywhere from like $3 to $5, medium $5 to $10, and they increased up to jumbo. Next slide. So this was our initial prize jar. We used gloves when we were pulling from the jar to reduce contamination between clients. Next slide. Prize tracking for clients. So the guideline does recommend using these tracking slips to assist clients, remembering when to come, how many pulls they'll get if they're negative. We found out very quickly that the clients didn't find them helpful and they often ended up on the floor. So this was the only modification we made to the protocol. Instead, we verbalized what the client was going to be getting for the following Friday. And when we were implementing reminder calls, we would remind the clients that way. And to assist our staff and track our clients, we amalgamated contingency management into our EMR program, color coding and setting reoccurring appointments for each sample. This helped us to track no-shows and tracked when clients miss sample days. Next slide. We also created a standard e-form for clients on contingency management that allowed us to track which week, which session they were on, and if they were positive or negative, which prizes they picked, and to see if we were reducing police visits and hospitalizations for clients. The larger challenge with implementing contingency management into any RAAM clinic was getting creative in implementation. We did not receive any additional funds for staffing for this, so we had to get creative and build this into our current workflows. We divided this up into 2 staff members. One was a lab technician that would do the point of care test results and enter in the results. And then the other one would be a case manager who would then assist the clients with picking out the prizes. We tried to reuse current templates just to make this easier to only add 1 to 2 minutes for each client onto the staff member. We had reception call case management, reception call and case management call clients when they didn't show up for appointments. This seemed to be the overall question that we got from other clinics is how did you implement this without additional staff? And it was literally making sure we implement this into your current workflow. Next slide. This just shows the breakdown of what the lab technician did and the case manager. Next slide. So when this just shows that when the clients come for how contingency management essentially works when clients come in. So their first visit, when you sign them up, you start with priming. We try to do it the day they sign treatment agreements because then they get to pick until they get a prize, regardless of positive or negative results. And then the second visit, if they're negative, they draw one, they get to draw once. And then the third visit, they draw twice and it increases up to 8 draws in total. If at any time a client's positive, it goes back to 1. Next slide. For any clients that had an absence, it went back to 1 unless they had reasons. Some things that came up if clients were positive for COVID or if they were unable to make it due to other appointments, they would get a pass and not be reset back to 1. Next slide. The treatment agreement. So we created a treatment agreement for our clients and our staff. This assisted all of the staff in the clinic so that essentially anyone could start contingency management. Whether it was a physician, a counselor, they could go through the program with the client, explain the guidelines, the rules, and also explain if the client had a history of gambling or prescribed stimulants that they weren't applicable for the program. Next slide. And then all the clients that completed the entire 12 weeks without dropping out, regardless of positive or negative samples, received a completion certificate. One of the benefits we see in contingency management is that it helps clients stabilize their life. Often clients get overwhelmed attending appointments. So we found that it was important they felt rewarded just for coming and committing to the program. Next slide. So when you're initiating contingency management with a client, Day one, you have them sign the treatment agreement. We provide them with a copy. We give them a tour, open up the prize cabinet, get them really excited. We start priming immediately. They get to pull until they get a prize. And then we set them up with like a counselor or case manager to help create a weekly schedule, give them strategies to avoid using, and remind them when to come in next. Most clients don't do well with scheduled times. So we made it scheduled dates as opposed to times. So clients could come between the hours of 8 and 4 on a clinic day, as opposed to having to come at a specific clinic time. Next slide. As I said earlier, the largest challenges with contingency management was the cost in prizes and the human resource component. We did not get additional funds for this, so we used remaining funds from budgets, donations to try to launch our program. It's estimated that it costs an average of $262 for one patient for 12 weeks. And that doesn't include the other costs like cabinets and test strips. On average, it added about 15 minutes for each patient divided between 2 roles. But it is a program that you can implement with little additional staffing funds for sure.
Okay, so and we hope we really want to leave time for questions to sort of ask about the just nuts and bolts. So this started in 2020 in January, so you can imagine how that went. Things we didn't expect were a global pandemic where everyone was worried about people touching the same prize slips. So about week 8 of this first implementation, which was a fixed group, so basically all the patients started the 12-week program at the same time. And we really had to figure things out by like week 9, and that really disrupted it. We offered it at that point with a CRA program, and we did it as a standard clinical implementation. So based on the fact that it is in the guidelines and it is recommended and it has been extensively studied, we were offering this as just part of clinical care. It was entirely voluntary. It was certainly, offered to people as like, this is an option if you're interested, and some people were interested and some people weren't. And we offered it just for stimulants because we didn't have other things to offer, and resources are very limited. And so it was offered only for stimulant use disorder. Because the immunoassay will pick up any other stimulant like prescribed amphetamines, we could not include anyone who was prescribed stimulants, medically prescribed. So it is a low risk intervention. The only exclusion again is gambling. And so we started this at that point. There were a number of identifiable gaps. Although this is such good evidence because it is like a human resource issue, because it's complicated. It's an intervention. It's not like a medication you prescribe. And the cost. It generally isn't implemented. It's been implemented at the Veterans Affairs in the US, but really very few other places. And sort of the combination of needing someone to do urine testing and so on, it really does add to kind of complexity. And a lot of this data is now 20 years out of date. So we really wanted to know, like, is this going to work in a RAAM setting? Is this a good place to do it, especially without the infrastructure of an RCT? So often this has been done in the infrastructure of a randomized trial, but pragmatically, when we have no extra resources, no extra staff, how does this work? And what would the prizes look like today? So those are kind of the questions we had as well. So initially, one of our projects was like, okay, we've done this, we've implemented this in a RAAM, but does it compare to the implementation, in the RCTs? And then are the types of prizes, could we identify the prizes most commonly selected? And finally, our third kind of objective was, this is really, labor intensive. Could we figure out and test software which automates some of this to make this easier? And at the end, if we have time, we'll show you kind of our test of an EMR optimization that would help do that. And some additional aims were just to also, show that this works and, help kind of, encourage funding for this throughout Ontario health teams, and to see if there's other ways we could find to effectively spend resources so that we could optimize the purchase of specific prizes. So we did actually ask for research ethics approval for a quality improvement project. So again, this is an observational study and quality improvement, not a randomized control trial. Both from CAMH, the special project ethics review for quality improvement projects, and the Brant General Hospital approved the project. So first, with this implementation from 2020 involving this standard protocol, we were just observing how that went. That was including anyone with stimulant use disorder and a self-identified goal of abstinence and interest in the program. We excluded anyone, again, clinically who was prescribed stimulants or had gambling disorder. And first just did a retrospective analysis of those patients in 2020, 2021. And then we are now in an ongoing analysis of patients who were enrolled more recently to see if, with the quality improvement we've done, to see if that's going to improve outcomes and implementation. So these are the first results from the first process. Again, we started off in 2020, but the actual patients were over a longer period because of the COVID pandemic being declared. There were 17 patients, the vast majority male. We had 3 dropouts, which was very informative because those all occurred basically in the first week of the program, which became a point of improvement in the process. And our total weeks of abstinence were 2.65, which you can compare to 2.8 in the literature. And the consecutive weeks of abstinence were 2.18 compared to 1.7 versus standard care. So very comparable to meta-analyses that have been done for contingency management. And we now have 22 patients currently enrolled in the program. And again, we're comparing, pragmatic process in a clinic with no extra funding compared to largely research studies that were funded to test CM compared to like a placebo or standard care comparison. And so, at approximately week 10, we really had this dramatic impact in in-person care that caused this whole project to be disrupted. For example, the group had to be canceled. And nonetheless, we have fairly comparable results in a population of patients who are essentially mostly also enrolled, in the equivalent of what would be a methadone clinic, but what is a RAAM clinic. So they may be receiving treatment for other things. This is not a randomized trial, it's pragmatic, and it lacks a number of resources like research coordinators who would be phoning patients. It's obviously small sample size, and we're excited to see what the next round of results brings. I think the patient feedback is really important. So I'm just going to leave this up, but patient feedback was really positive. Patients who chose to be in the program did like the program. They enjoyed the flexibility, and I just want to highlight some things Stephanie said. So, I think one of the difficulties in making this available is the fact that it has to be done twice a week. But, we do Tuesdays and Fridays, for example. It has to be really any time during clinic hours on Tuesdays or Fridays. That's very difficult with human resources. We would normally expect the staff to say, okay, your time is at 10 o'clock, but the patients in the program really wouldn't be able to make that work. And so figuring that out with your workflow is just incredibly important to actually making this available. Okay. And so now the quality improvement parts, I'm going to hand over to Himmat.
Great, thank you, Dr. Hauck. So I will now be explaining the quality improvement process we followed over the course of our CM program. So studying the delivery of CM and improving that delivery is very important as healthcare resources are limited, both inventory-wise as well as human resource-wise and time-wise. So the application of CM should be targeted so that it is timely, it is effective, it is efficient, and patient-centered. And these are our 4 domains of quality. We can study the quality improvement process through a PDSA cycle, which we can see on the right. And P stands for planning, D for doing, S for studying, and A for acting. It's also important to note that this was a quality improvement project, as Dr. Hauck was saying, so no intervention was tested. CM has been shown to work in the literature, so we were simply studying CM to streamline the process in our RAAM as well as other similar clinics. Next slide, please. So here we can see our 4 domains of quality. The first domain is timely. So what this means is, are patients receiving CM at the best time? For example, is it best to receive CM before? Is it best to receive CM before or after residential treatment? And that was a very common question in our program. The next domain of quality is effective. So is the program equivalent to standard protocols for CM in stimulant use? And is the delivery similar to protocols described in the literature that have been shown to be the most effective? The third domain of quality is efficient. So is the program efficiently using limited resources, whether that's inventory or staff and human resources? Healthcare resources are limited, and especially today we can see that. And many medical facilities are short-staffed. So inventory and pricing must be taken into account. The fourth domain of quality is patient-centered. Are patients satisfied with the program? Are prizes consistent with patient requests? And will the program motivate patients to succeed? For CM to work, the clients must desire the prizes that are to be earned. Next slide. So the first thing that I noticed when I was retrospectively analyzing our data from 2020 was that patients were likely to drop out from the program entirely if they missed the first few sessions of CM. And by the first few sessions, I mean the first 1 to 2 sessions. In contrast, I noticed that patients who attended the first few sessions of CM were more likely to complete the program. So in response, last summer, taking this into account, my aim was to reduce the total number of dropouts in the program and have patients complete and finish the full course of the program. I acted on this by engaging in reminder phone calls to clients the day before, reminding them that their CM program was the next day. I also printed out paper calendars for patients to keep track of their weekly CM appointments. And I offered flexibility in clinic hours. So patients could come in for their appointments during any of our clinic hours. And this was completely different from before the first round of patients on the program who had set appointment times. And so the QI domain I was targeting here was effective. Next slide. The Averos EMR that we use in clinic was very helpful for staff because they could see who was coming in for CM that day, and the patients were highlighted in a different color to make them stand out. It was also useful for patients because we could print out CM session appointment dates and times from the EMR and hand it to them when they left, so they knew when to come in next. Next slide. Another aspect I noticed during our CM program was the need to use clinic supplies efficiently. In particular, we experienced a clinic shortage of aminoassay methamphetamine dipsticks over the course of CM, and this was partly due to a general national shortage. But despite this shortage, my aim was to continue to provide CM to our patients. So I measured where and how the methamphetamine aminoassay dipsticks were being used in the clinic to see if they were being used in areas that may not be needed. And on our EMR under disease registry, it showed stimulant use disorder for patients who have stimulant use disorder. But this may mean methamphetamine or cocaine use. It didn't differentiate. And so we were testing anyone with stimulant use disorder with both a 6-panel for cocaine and a methamphetamine dip as well. So one significant area that improved our efficiency and use of methamphetamine dipsticks was changing the general stimulant use disorder under disease registry to specify either methamphetamine or cocaine use, and only testing individuals with methamphetamine use disorder with methamphetamine dipsticks. Another significant area that improved our use of the methamphetamine dipsticks was updating our disease registry for clients. And that allowed us to not test individuals who maybe once had a methamphetamine use disorder, but no longer do. And so the QI domain that I was targeting here was timeline. Next slide. A common dilemma in our CM program for patients and for staff was deciding when the best time would be for CM administration in relation to residential treatment. So should it be given before or after, and why? This presented a problem for many of our patients because they were interested in the CM program, but they didn't know if they should do it before or after residential. And staff didn't have an answer for that question either. So in response, we did an observational study over the course of the summer. We measured the weeks of abstinence in a group coming from a controlled environment. So that means residential, hospital, withdrawal management, incarceration. And this group would theoretically be abstinent starting the program. And we compare that to the weeks of abstinence achieved on the program in a group starting without being placed in a controlled environment. And hence they would theoretically be non-abstinent when they started the program. So in summary, we were comparing two groups success on the CM program, one group coming from a controlled environment and theoretically abstinent starting, and we were comparing that to another group who didn't come from a controlled environment and theoretically would not be abstinent starting the program. And so we measured this, and after studying this, those who started off stimulant negative, coming from that controlled environment, achieved a higher number of weeks abstinence on the program. And many of those who started off stimulant negative were some of our most successful clients on the program, often achieving the full 12 weeks without stimulant use. So in response, we now recommend and offer CM to clients after residential treatment or withdrawal management. And those results are based on preliminary data. We're continuing to monitor this process and study it. So this is an ongoing PDSA cycle. And the QI domain that was targeted here was effective. Next slide, please.
In such a high volume clinic that serves dozens of patients daily, it was important to us that we found a way to optimize the staff's efforts put towards the CM program. With our original model of 2 staff members administering CM, one was heading the prize drawing and selection, while the other enters the data. And 6.5 hours a week was dedicated to the program, which translates to approximately 16% of a 40-hour work week. And we decided this just wasn't sustainable, so we looked to technology for alleviation. Software was then implemented that automates the process of drawing the size of the prize, so either a small, medium, large, or jumbo prize, which eliminated the time of drawing from the paper raffle bowl and tracked the prize category selected. It's important to note that with this transition, the patient still had the freedom to select the actual prize within the category generated, but the software, it didn't change the process for CM, but it does allow for staff to have faster data entry processes. And since this pivot to technology, the efficiency of administering CM increased as each appointment required less time, and compounding all of this reduced time actually created greater opportunity for more patients to enroll in the program. And it should be highlighted that this method worked most effectively in this clinic specifically and could vary among different clinics. Contextually, the adoption of automation is one that is very necessary in the healthcare field as a whole. As displayed on the slide, the Ontario Medical Association Burnout Task Force suggests that the first solution to addressing physician burnout is to streamline and reduce required documentation and administrative work. And while this mitigation strategy is primarily targeted at physicians, it really is applicable to all healthcare workers. And as further listed, we use the guidance of the third strategy by using automation and technology to alleviate workload. And as evidenced by the greater efficiency and ability to enroll more patients in CM, as mentioned previously, this method proved to be effective. When the CM program originally launched, we had no data on popular prizes from patients in the clinic, so a variety of prizes in each category were purchased for patients to select from. And as the CM program progressed, we created an Excel spreadsheet to track the prizes that were being selected. With this information, we were able to track the prizes that were more consistently chosen to restock them as necessary, so patients would have the option to select from prizes that were more preferred. With this, we continued to add new prizes to the inventory that were not part of the ones that were strongly selected, as we wanted to maintain the prize options to be wide. Often, some of the new prizes that we implemented into the inventory actually became ones that were more frequently selected, and we ensured to keep them in high stock. We thought it was important to add prizes that were more strongly preferred while continuing to add new prizes to the inventory to optimize patient incentive. And we found this to be a successful method, as many patients selected the same prizes every visit, and we're excited to see when more of them were added. Since the CM program was originally only housed in the Brantford location of the clinic, patients who seek care from the Simcoe clinic would need to travel to Brantford twice a week to participate in the program, but we quickly learned that this travel time was just unsustainable to happen twice a week. And so consequently, many of the Simcoe patients enrolled in the program would be absent from their CM appointments due to this required travel time. With this, we decided that this was both an unfair representation of patients missing their CM days and actually an unfair ask for the patients to make this inconvenient travel, as many of them have work and other commitments. In response, we brought prizes to Simcoe and delegated one staff member to administer CM on a Monday and Thursday schedule. Mirroring the process outlined previously, we created a separate Excel spreadsheet to track the prizes that were being selected. We thought it was important to create a separate spreadsheet as that in Brantford because it would allow us to add the inventory to the two different locations separately, according to the stocks of each prize. Adding this new CM branch in Simcoe created more traction in the program as more patients were able to enroll and actively participate in CM since they no longer had to make the trip to Brantford. Furthermore, this caused fewer appointments to be missed, which would have been attributed to the travel time, and patients were grateful of our efforts in adding a new location closer to them so they too could be part of CM.
Okay. So that's pretty much our content. Just to kind of go into a little bit of a bigger picture piece here. We have some general strategies, which I don't think we'll go through, but considering stimulant treatment overall, because it is a really important thing for many of our clients that they come seeking care for. I just wanted to mention that. And then just a lot of thank yous. So there are references at the end, but a big thank you to the whole team at the Brant, Hallam, and Norfolk RAAM. This was the original picture of the RAAM. Some shout outs to a few people. So Dr. Barra, who designed some software that I'm happy to show everyone if we have time, and for all of his work in stimulant use disorder, and especially to some of the people who have really made this all possible. So Himmat and Basant, who did all of this implementation, Eleanor, Crystal, and Carl, who do a lot of the work in the RAAM with this, and the entire RAAM team who's implementing this every day and doing this with clients and making this part of their workflow, which again, that's really one of the hard things is that, this has to fit into something that is already running. And thank you to our collaborators, Dr. Ahmed Hassan and Tim Guimond, who are not here today, but have really helped with the interpretation of the data in comparison to some of the literature.
Okay, so I just want to say thank you so much to our speakers. Does anyone have any questions that they would like to ask at this point?
So I see a question from TTS John. I don't know if you can see it, Stephanie. This is really one for you to answer. and Himmat and Basant. So I'll read it out. I love the idea of giving clients the choice of time to come to the clinic. From your experience, was the afternoon busier? Any lessons learned from managing the flow, assuming more late afternoon visits?
Our morning was actually busier for sure. I think on our Fridays, we've seen the afternoon was more busy, but in terms of patient flow, you have to build this into like what you're currently doing. So for us, for instance, when clients walk through the door, they immediately go to the desk and they see reception. We put everything side by side so that the staff at the desk could easily do contingency management without having to also separate from the current tasks that they're already doing. It helps to have a room very close to your desk, probably like a foot if you can, or 2 feet next to the desk, just to help staff and support the clients so that they do have some privacy, but also that they're not going too far, because they do worry about like things like missing their appointments. And it's honestly the best way to do this is to make it as least time consuming as possible and fit it into what you're already doing.
Yeah, I should mention, and we didn't say this a lot, we do have a lot of patients coming in for opioid agonist therapy. So that's why the morning would be busier, because it would be mostly people coming in the morning at the same time that they might be having their weekly appointment or getting their medication. So the mornings would typically be busier. But if the afternoons will be more busy, then you'd want to kind of fit it in there. And it certainly, I think it would be very difficult in the way that we did this to implement this in a clinic that doesn't do urine samples. So adding like a urine sample piece, if you're not already doing urine samples, would be like quite a big change and would create more staffing concerns than we, I think, had based on the fact that that was already part of the workflow.
Thank you. It looks like we have another question from Marilyn asking if there was any age-related differences.
Himmat, did you notice any patterns? I don't think we had very much data with a large range.
So based on our preliminary data, we didn't analyze any sort of age factors, but that would be definitely an interesting statistic to look at with our next round of patients. So yeah, thank you for bringing that up.
I think too with prizes, that's a really good point. Like also like the type of prizes patients might want is like having a variety of, I don't think we had very many older adults, just to answer Marilyn's other question. I don't think we had very many. We do have clients in the clinic, but I don't think in contingency management we had very many.
And then just to answer the question, if prizes were drawn in a private area or in front of others, they were by our waiting room. We had essentially like just a small room. So the waiting room could see the prizes, and we found that it actually motivated other clients to want to do contingency management because they would say, well, what is he doing? And they would get very excited and want to kind of join into the project.
Other take homes that I don't think we expected was like candy and chocolate is just like far and away like the most popular thing. And I think about it too when we do like gift prizes at resident teaching, right? Like everybody wants candy.
And also add when other clients saw CM participants walking away with prizes, they often would ask about the program, and it would kind of translate with word of mouth.
That's really great to hear. I'm not seeing any more questions come in, so I'm wondering if you wanted to take a few minutes to show the software.
Yeah, so I'm just going to pull up that. Just 1 second.
Thank you, everyone, for the questions that you submitted.
So big thanks to Dr. Parminder Bara, who made this for us. This is still in like the testing phase, but very exciting because, again, the human resource aspect is just, and the documentation is just such a big thing. Stephanie, do you want to explain how it works?
So the date, the patient's information auto-generates from the EMR, and you would just click the top where the week is, and it would put it to the correct week. And then you would click the session, and then it auto-generates the total sessions, and then what the last draw was. So what the previous draw was, you'd put the urine drug screen result. So if it was positive or negative, and if it's positive, it'll automatically say they don't get a draw. And if it's negative, it'll generate how many draws. So this is super helpful because a lot of the time comes with looking up in the chart and figuring out where clients are. And then just the police visits and hospitalizations, and then the prizes, whether they're small, medium, large, or jumbo. And then at the end of it, you hit generate summary and it creates like just a line in the EMR on the main page so that you can actually see lists of them and the doctors can see them. It's been really helpful.
Well, we can't speak for, everything. Obviously, we haven't tried all kind of ways of documenting, but we use Oscar and now Avero, and it has this ability to customize forms for documentation, and that's just been absolutely essential to actually implementing this and trying to record this information and do quality improvement and know if it's working without having to have even more people spending even more time inputting all of this information. So that's just such an essential part of this, and probably one of the bigger barriers too to actually, why aren't we seeing more CM implemented more widely?
This is great. Thank you so much for sharing. I noticed that a few more questions came in. We have Marilyn asking, do you give TTC tickets?
So we are in a part of Ontario that does not have public transit. Is that a fair comment I can make, Stephanie? Brantford does.
Brantford has a bus service, and we did have bus tickets out there. Simcoe and Dunnville do not have public transportation.
Thank you. And we also have a question from Lori. What program was used to create this EMR tool?
So that was Avero.
So Avero is the EMR, and within Avero, you can make custom e-forms to add any kind of information or form. So you could do like a custom consent form, for example, and then have the patient sign it, and that'll actually scan it as a PDF into the Avero, and it'll become part of their record. I can't underemphasize the magic of this when you're used to like a rigid EMR that doesn't let you do stuff like this. It's just totally life-changing, like how this can create like the thing you actually need. And what we're going to add to this is actually to put the draw. So my dream is to have like big red buttons for like the draw, so that if there are two draws, two big red buttons would come up on an iPad, and the patient would like press the first button, and then it would say like no prize, and they press the second button, it would say like medium prize. So they would do the draw right there, and they would do the draw because, CM is, based on that dopamine response, right? So you actually need the patient to do the draw themselves. That's the whole point. And to select the prizes. You can't automate that, but we could at least then have it in the system all connected so we don't have to deal with like slips in a bowl.
That's great. Thank you. So I'm looking at the time, and I want to just take an opportunity to thank our speakers for coming today and talking to us about this very important research project. And I want to thank everybody who joined this session. You'll notice that in the chat, I put two different links. So the first ask I would have is, if you have a chance, please fill out the session evaluation for this session. You can use the link in the chat. And the link will also be available in the session description on the agenda page of the platform. And we would also like to ask everybody to fill out the day one evaluation, which is also in the chat. And we will also be circulating it afterwards, after the conference, over email. So thank you all for attending day one of the PHI Conference. Tomorrow, we will be starting at 8:30 a.m. with some workshop sessions. And we want to just remind everybody to please use the same event link to access tomorrow's programming. So thank you so much again for being here, and we look forward to seeing you all soon.